morning, everyone, and welcome to the Grand Rounds. This morning's Grand Rounds is the brainchild of Mike Miedema in honor of the importance of prevention to the work that we do here at this institution. We have a wonderful speaker that Mike will introduce in a moment. But the celebration this morning is in honor of Kevin Graham, who sort of is the godfather of prevention at this institution. I think everyone knows Kevin's passion was for prevention in cardiovascular disease. Kevin founded the Under 55 Registry to study coronary disease in younger patients, and many of those patients that he cared for are now in the over 85 registry, so they've done quite well. Kevin was the president of our group from 2007 to 2012. And he was instrumental in the start of the Heart of New Ulm project, which continues to this day, 10 years after its inauguration, and in studying the importance of prevention in a large community. So Kevin is here today this morning with his son Peter and his cousin Dave and his caregiver Rima. And we welcome them and we salute you, Kevin, for all you've done.
Good morning. So I am very honored to present our speaker today, Dr. Phil Greenland. Dr. Greenland has been influential in my kind of pathway into preventive cardiology and cardiovascular prevention, and so we're very honored to have him. He trained, did his MD at the University of Rochester, New York, as well as internal medicine residency there. He then came to the University of Minnesota, where he did his cardiovascular fellowship, and he's one of the eminent researchers in cardiovascular prevention. He's currently the Harry Dingman Professor of Cardiology at Northwestern University, and he's also one of the senior editors for JAMA. So without further ado, Dr. Greenland.
Thank you, Mike and Scott and Dr. Graham. It's a real honor to have the opportunity to be here today and come back to Minneapolis after a number of years away and reconnect with people here. So after a little bit of negotiation with Mike about what the topic would be here, we decided that we would do something related to past, present, and future of precision cardiovascular prevention. And the outline of this talk is I'm going to try to run pretty quickly through past and present, because I assume most of you know that. And then I'm going to spend probably half the time at least speculating about what the future might look like for preventive cardiovascular medicine and precision medicine. So these are my disclosures. I don't have any relationships with industry, but if anybody wants to negotiate something later, you know, I have a little time afterwards. So in terms of the past, I don't know if there's anybody in the audience here who remembers who this guy is, but it seems to me that before we spoke about precision medicine, we talked about personalized medicine, and to me it was sort of epitomized by Marcus Welby on television, and that was the image that I had when I went to medical school, was that, you know, I would have an hour or 2 hours with each patient, and you know, after getting to know them extremely well, then I'd be able to make the right decisions about them. But by about the 80s, there was some discomfort with that idea of the personalized decisions related to one-on-one doctor-patient, because there was a feeling that we didn't have good data to be able to be making those decisions. And then the movement at the time was evidence-based medicine, which we still sort of are living through. But the future that some people talk about anyway is this idea of precision medicine, where, as sort of depicted on this slide here, that we would have the ability to integrate data from the genome, the environment, from the patient's lifestyle, representing, you know, everybody, the whole country, all the diversity of the United States, and then be able to make much more informed, and at least in theory, what people are talking about is literally individualized decisions. And at the end of the talk, what I want to talk about is is that a possibility? Is it really realistic, and are we even close to it at this point? So for some of you in the audience, this is not big news, but there was, from what I can tell, there wasn't any thought of preventive cardiovascular medicine before about 1950. And by 1950, we were already well into the cardiovascular epidemic in the United States. And some of you are familiar with the history work that Henry Blackburn has been doing. Henry is one of the absolute leaders in cardiovascular disease epidemiology and prevention at the University of Minnesota and known around the world. And Henry has put together a fantastic set of web pages in the University of Minnesota website describing the history of various aspects of cardiovascular medicine. And one of the pages he says here, in hindsight, any discussion of either the pathogenesis or the treatment of coronary heart disease seems conspicuously absent from the classic texts of cardiology until Paul Dudley White's textbook in 1941. And then he says, and even White, who turned out to be one of the greatest advocates for prevention, even as late as his third edition in 1948, makes no mention of prevention at all. Now, partly that was related to the fact, as we all know, the data in support of prevention was not very good in the 50s, but even the possibility of thinking about prevention wasn't mentioned. By the 1950s, though, Dr. White, who was, Eisenhower's cardiologist, and who rode his bicycle in Boston to Mass General, and everywhere else. And, this is Dr. White in his 80s riding his bicycle. And he said this great quote, "Heart attack after age 80 is an act of God, but before 80 is a failure of medicine." So when I was doing my medical school and residency and starting my cardiology fellowship here at the U in 1978, that was about the time I think that I would date the sort of beginning of preventive cardiology. And yet there had been experimental animal work going back to the 1920s on cholesterol and atherosclerosis. There were data related to smoking and cardiovascular risk that the life insurance companies knew about back in the 40s, for sure. There's evidence in the life insurance data that they were aware that cigarette smoking, hypertension, and high cholesterol were associated with heart disease as early as the 40s. But as you all know, the sort of beginning of the idea that we would have data to support prevention was really coming out of Framingham, which started in 1948. And the first papers from Framingham came out around the 1960s, and actually, from what people say, even the term risk factor, which we use every day in clinical medicine, talking about any number of different diseases, the term risk factor supposedly was first used in this paper by Cannell from Framingham, reporting the 6-year follow-up experience from Framingham. And this paper was in Annals of Internal Medicine in 1961. So they basically invented the term risk factors. And one of the things that's interesting from this paper that I just wanted to mention in thinking about the past of precision cardiovascular prevention is that even as early as this first paper in 1961, they were showing that there was a association between cholesterol and blood pressure and CHD outcomes, and that if your cholesterol was high, you were on a different curve than a person who had a lower cholesterol. And if your systolic blood pressure was particularly high, you were also on a different curve. And so there was this interaction between the lipids and the blood pressure such that you wouldn't imagine treating a patient with high blood pressure who also had high cholesterol the same way that you would treat a person with high blood pressure and low cholesterol. So there was already the beginning, even as early as the 1960s, of the sense that we could personalize at least the risk of cardiovascular disease. But even up until about 1975 or 80, how many people trained after 1975 or 80 here? Mostly everybody, okay. Up until that time, we had relatively little data on intervention. And the first data on intervention really started coming out in the 60s and 70s on high blood pressure treatment. And I'm just showing one slide on this because I think this is really interesting. This comes from a very recent paper in the European Heart Journal where after the new blood pressure guidelines came out from Europe and the ACC-AHA, as you all know, this has generated a lot of controversy about, what level of blood pressure should be considered normal and what level of blood pressure should be treated. But this is not a new discussion, right? This has been going on for over 30 years. So if you go back and look at all the different recommendations to treat blood pressure, we started out thinking that we would only treat systolic blood pressure if it was greater than 160. And then comes along the SHEP trial and the STOP trial and the SYSTURE trial. And by JNC5, the recommendation starts to get down to treating people at 140. And similarly, early in the game, based on the HDFP trial and the VA trials, we were only really treating diastolics that were, well over 100. And nowadays, we're arguing about, well, how low do we go in terms of treating both systolic and diastolic? And the idea there, I think, is that we're progressively personalizing the way we think about the risk associated with hypertension. And the same is true for lipids. We didn't really have any clinically strong data about the role of intervening on blood lipids until 1984. And, I'm sure many of you remember, this is a classic paper from a JAMA publication on the Liver Research Clinic's coronary primary prevention trial, where, I don't know how many people remember using cholestyramine, but this trial, this was a pre-statin trial. Let's see if I can. Pre-statin trial, and we used cholestyramine, which modestly lowered LDL cholesterol in people who were willing to take it. Any of you remember using cholestyramine? Okay, a few people. It's like sand. Okay, it's a little packet of a granular material that has sort of the consistency of sand. And you mixed it up in orange juice or whatever you could tolerate. And it's a bile acid resin. And the study showed about this 15-20% reduction in cardiovascular events. And suddenly, there was a realization that by lowering LDL cholesterol, we could prevent the development of coronary heart disease, at least in some people. And then a year later, 85, was the Nobel Prize to Brown and Goldstein for all the work related to the LDL receptor, and then very, very quickly, the development of the statin drugs. So, this was a landmark event in cardiovascular medicine, and from my point of view, this is really the beginning of what I would say is preventive cardiology, because really for the first time, clinicians started thinking that it wasn't just about risk assessment anymore, it was about risk assessment and treatment. And again, I don't want to spend a whole lot of time on this because I think this is really past history, but once we had those data, the NHLBI and AHA and ACC quickly organized and developed guidelines for cholesterol management. The first one was 1988, and you're all familiar with the the fact that by 2001, by ATP3, the third cholesterol set of guidelines, the recommendation included this concept of doing a risk assessment in order to go back to that 1961 recognition, the paper that I showed you earlier from Framingham, that the risk factors are all sort of interactive with each other and additive. And so if you didn't know the full risk picture, you couldn't really personalize the treatment. So that concept was, really introduced about 2001, and it's been further modified in 2013. Everybody's familiar with, this sort of concept of the different statin benefit groups. And again, as we know, there's been a lot of sort of discussion about the accuracy of the risk calculator, the pooled cohort equation. At least from my point of view, I think that that sort of argument has largely settled down. Been a number of papers like this one that have validated the relative accuracy of the pooled cohort equation. And so I think nowadays, everyone I'm sure in the audience here is very familiar with the idea of doing risk assessment and trying to figure out in a sort of personalized way which patients should get which kind of treatment. Mike probably knows I can't give a talk on preventive cardiology without talking a little bit about coronary calcium. And I think this is sort of the transition from the past part of the talk to the future part of the talk. And what I want to mention here is that, my own particular initial interest in this was related to the fact that there used to be a company called Heart Check America, and they started in Chicago. And what they used to do around about 2000, when they first started doing electron beam CT. Anybody familiar with electron beam CT? Okay, so electron beam CT was the first technology that was able to do a CT scan fast enough to be able to get an image of the heart that was basically still. And the advantage of it was that it was very fast. And the disadvantage of it was it didn't get very good images. So it was capable of identifying calcium and quantifying the calcium, but it wasn't very good at getting images of the brain and the rest of the body. So it was essentially a very expensive technology that could only do one thing, measure coronary calcium. And so the few places in the country that had these electron beam CTs used to basically sell them. And there were lots of advertisements and things like this. And we happened to have two of them in Chicago. So I used to drive to work listening to advertisements that went something like this. I'm a 50-year-old man. My wife saved my life. For my 50th birthday, she ordered a Heart Check America test, and I went and found out that I was a ticking time bomb. I had coronary calcium, and I was going to get a heart attack any minute. And so I got revascularized and so forth. And I said, what's the data for that? What's the evidence that we would be able to go from the identification of coronary calcium to knowing that the person needed revascularization? And so that led to a number of research studies, but the one that we participated in was the multi-ethnic study of atherosclerosis, where Mike and I have interacted on that study. Started in about 2000. It's still ongoing. We studied 6,000 patients, 6,000 people, sorry, not patients. These were healthy people that were recruited to participate in the study. They were between the ages of 45 and 79, 45 and 84, sorry, 45 and 84. And we've done a number of studies on them over the years, including repeated CT scans. repeated carotid ultrasound and abdominal CT and a number of other studies to try to understand the precursors of atherosclerosis and clinical coronary disease. And the landmark paper from that study was published about 8 years ago or so in the New England Journal of Medicine. 10 years ago, New England Journal, 2008. It's been cited hundreds of times. And you're probably familiar with some of these data. What it showed was that people who had zero coronary calcium in this study over a 5-year period had almost no cardiovascular events. And people who had some coronary calcium, moderate coronary calcium, or high amounts of calcium, greater than 300, had much more frequent cardiovascular events. And the odds ratios from this study are pretty interesting because for major coronary event, people who had greater than 300 compared to people with zero had about 7-fold higher risk. And for any coronary event, meaning heart attack plus revascularization based on symptoms, the hazard ratio was close to 10. So that's a fairly impressive level of risk for a cardiovascular risk factor. And subsequently, what's been shown in the MESA study and a few other studies as well is this interesting finding that even if you categorize the risk factors and look at people who have no risk factors, this is also from the MESA study, people with no risk factor 1, 2, or 3, their coronary calcium could be either zero. They have zero risk factors. About 2/3 of them had zero coronary calcium. But notice, about 5% of people who had no risk factors at all had coronary calcium greater than 300. And there is this association between the number of risk factors and the calcium score, but within each of these categories you find reasonable numbers of people who have different levels of coronary calcium. Consequently, in the MESA study, we've looked at the combined association of risk factors like Framingham risk score and coronary calcium score. And if your calcium score is 0 and your Framingham risk score is even very high, higher than 20% risk, you still have a fairly low risk. So that's telling us that coronary calcium is a very strong indicator of low risk if your calcium is 0. And of course, if you have high risk factor burden and high calcium burden, your risk of a cardiovascular event is very high. So again, this is another one of these tests that we've identified that helps us personalize exactly how we're going to assess a person's risk and decide how intensively to treat them. And I'll give a little plug for this paper that we had in JACC recently where we tried to summarize all of this. This is the central illustration from a paper from JACC a few months ago. And we tried to kind of summarize based on the pooled risk equation score and the likelihood that coronary calcium would be additive or not in personalizing risk. So I think that's sort of my quick overview of past and present of personalized or precision cardiovascular risk assessment. And what I want to do is transition into talking about where we might be going in the future and talk about some of the genetic testing and that sort of thing. So what's the future of preventive cardiovascular medicine? So let me start with this quote. So many of you here probably are familiar with Dr. Lascalzo, the previous editor of Circulation and a very eminent cardiovascular physician and scientist. And in this paper that came out in Circulation Research, he says, precision medicine is poised to become the next great revolution in the practice of medicine, as well as in the maintenance of cardiovascular health and prevention and cure of cardiovascular disease. And he goes on to say that we're going to be able to create, and this is what I want you to really think about, because people are saying things like this, and it's not just Dr. Liscalzo, it's Dr. Francis Collins, who's the director of the National Institutes of Health, and many other people are suggesting that we're on the verge of a totally different kind of medicine that's going to be not just personalized in the sense of Marcus Welby, but actually precision, to the point that he says it's going to be person-specific. We're going to be able to identify the individual phenotype of each individual and identify an optimal intervention for that individual with minimal risk. He goes on to say the benefits are obvious of this approach to patients, clinicians, and researchers. So just want to put in this one slide here, because when I have started reading about this area and thinking about it more, I remember this quote that at one time I was in the dean's office at Northwestern, and the chief executive officer of the medical school used to say, you know, Phil, it would really be better if we under-promise and over-deliver. And I have a sense that in this area we may be over-promising and under-delivering, and that's really what I want to suggest. And I'll try to give you some evidence for that. So the idea of precision medicine is this, that in the current standard of care, what people are suggesting is that we have a population of people, advocates of this precision medicine approach say that what we do, despite the fact that I've shown you evidence that we do personalize, and I think we do a reasonably good job of personalizing, the folks that are proposing that we move to a precision medicine say that what we're doing with populations is a generalized recommendation. One size fits all. We're treating almost everybody the same. On the other hand, we have many different cardiovascular therapies that we could be potentially prescribing. And if we could get to the point that we could more precisely categorize the patients and start separating them out into different phenotypes. So they've depicted this by a red phenotype, a blue phenotype, a sort of orange phenotype. But the idea is that we would be able to separate subpopulations from the general population and provide a precision approach. Any of you treat cancer? Nobody. Okay. Let me just give you one cancer example, because I think that in the cancer field, there's a lot of talk about the fact that they've already achieved a sense of precision cancer treatment. When I first looked at the data, I thought indeed they had. But when I looked a little closer, I started to wonder if it's really only a modest increment in terms of what we'd like to achieve if we're talking about precision cancer treatment. So this picture is very similar to the one I just showed you. This happens to be a screenshot from the National Cancer Institute website. And on the National Cancer Institute website, they say that they've developed targeted cancer therapy. They've gone from this sort of generic approach, let's say patients with breast cancer, to being able to recognize that there are different types of people with breast cancer, that their phenotypes are actually different, that their tumor behaviors are different, and based on the fact that their tumor behaviors are different, we ought to be able to categorize them to the point that they get different treatments. So this is a prime example from the cancer literature of precision cancer treatment, and I think it's very instructive. So any of you familiar with a test called the Oncotype test? So just to explain it briefly, the Oncotype test is a gene expression profile test of the breast tissue itself. And it's used in early stage breast cancer to categorize the risk of the patient for a recurrence. And what the investigators who developed this test have shown is that there are different phenotypes. There are groups of patients within the early stage breast cancer who have relatively low rate of recurrence over 15, 16 years. And there's other groups of patients that look exactly the same clinically, but their breast cancer tissue has a different gene expression profile to it. And based on that different gene expression profile, they turn out to have different rates of recurrence of cancer. So this group here has a 7% rate of recurrence in 15 years. This group has a rate of recurrence of 31%. And if you look at their literature, they show that this is the score. This is the gene expression score that they report. And people at low score have low risk of recurrence. People with a high score have a high risk of recurrence. And based on whether you're categorized as low risk or intermediate or high risk, you get different treatment recommendations. So for example, today in cancer treatment of early stage breast cancer, if you are categorized as low risk by this test, you don't get chemotherapy anymore. So many of us, when we trained, every patient with breast cancer, early stage, got lumpectomy, radiation, and chemotherapy. And today, this group alone is getting recommended for chemotherapy. So let me just point out some numbers here so that you can kind of think about where I'm going with this. This group has a recurrence rate of 7%, this 31%. So the odds ratio is about 4.4%, excuse me. And 50% of the people are in the low risk group, and about 10% are in the high risk group. So it turns out there's an interesting paper that takes that information and sort of processes it so that we can understand what that really means in terms of decision making. And this is a paper that was published in Archives of Internal Medicine in 2011. And it points to a website. These guys are from the UK. They're at a place called the Wolfson Institute in London. And they have a website that's still active. You can take those numbers, the odds ratio and the proportions in the high risk and low risk, and plug them in. And you can end up with that information getting an ROC curve. And you can plot what the distributions of the risk scores are. So when I looked at that survival curve, I said, hey, this looks pretty good. This looks like we're able to separate people pretty well. But if you plug in that 50% are in the low risk group and 10% are in the high risk group, and the odds ratio is 4.4, when you plot the distributions, they actually look like this. So this is the scores of the affected group, and this would represent the scores in the group that didn't recur. And what that starts to tell me is that a test that I thought was actually precisely defining who should get what is only moderately defining who should get what. There's a lot of overlap here, and depending on where I put my cut point, I'm going to pick up a lot of people for treatment who appear to be in the low risk group. Is that clear? Okay. So I want to analyze a couple of papers that have been in the cardiovascular literature. Mike asked me about one of these last night. A few weeks ago, August 14th, 2018, I'm reading one of these emails that comes with, the news in cardiovascular disease. I'm reading the news in cardiovascular disease on my email, and it says that there's a new genetic test that can identify people at high risk for heart attack. And there's this picture of this, poor person having a heart attack. And it says here, Harvard scientist Sek Kathiresan believes polygenic risk score could help identify people at high risk. Now, hey, that looks really cool. And I also saw that there was a paper in Nature. This is an editorial in Nature, And it starts out with this headline, Giant Leap for Gene-Based Testing, Estimating Risk of Heart Disease, Breast Cancer, and Others. And then when I looked on the internet and searched around a little bit, I saw that actually this not only was in the cardiovascular literature and the science literature, but it's in Forbes. And you can imagine that if it's in Forbes, somebody thinks you're going to make money from this, right? So this is Dr. Catherine, and from Forbes it says, this Harvard scientist thinks he's reached a new milestone, a genetic test that helps identify people at high risk. So I said, hey, that looks really great. I better look up that paper, because Mike Meadham is going to ask me about that when we have dinner. So I looked up the paper, and this is a paper from Nature Genetics, and very interesting what they tried to do here in this paper. They said familial hypercholesterolemia has a risk compared to people who have the heterozygous condition for familial hypercholesterolemia have a risk of coronary disease about 3 to 4-fold higher than everybody else in the population. But the frequency of that condition is 1 in 250. So that's pretty uncommon, although some people think it's pretty common, right? But it's not as common as, let's say, you know, the risk of cardiovascular disease. So what he said was, what Dr. Catherine and Dr. Kara said as their hypothesis for this study is, could we find through genetic testing a proportion of the population that has a risk of 3 or 4-fold higher than the rest of the population? And they speculated that they could do this by genetic testing. So they developed a genetic risk score that includes 6 million SNPs. And they demonstrated that when they looked at the percentile of the polygenic risk score, there's an association between the risk score and the risk. That's not surprising, since they developed it based on the risk itself. But when you get out to the really extreme values here, the risk really jumps up a lot, okay? And when you're out at this extreme, what they report in this paper is that the proportion of the population that have a genetic risk score that's at least 3-fold risk higher than the rest of the population, that's actually 8% of the population. 4-fold is 2.3%, and greater than 5-fold is about 0.5%. And here's a box plot of the risk scores in the controls and the cases. This happens to be based on 500,000 people from the UK Biobank. Okay, so again, I looked at this and I said, that looks fairly impressive. But then they have this interesting table in the same paper. They say if you look at the top 20% of the distribution and compare them to the remaining 80%, the odds ratio is 2.55. So I said, hey, I know this paper from Archives of Internal Medicine from 2011. Let me plug these numbers in that paper and see what it looks like. So I plugged the numbers in. 80% of the population in the lowest risk group, 20% in the highest risk group, odds ratio 2.55. And here's what the overlap is of the risk scores in the cases and the controls. So if you look at this, and I didn't want to take you through a lot of this discussion, but if you look at this, it looks actually very similar to the distribution of risk scores from the Framingham risk score. Okay? And this ROC curve, I didn't plot the area under that ROC curve, but just looking at it, I'd estimate it's around 0.65 or so. Does that look right to you, Jim? Mike? Yeah. So what this is telling us is that this brand new genetic risk score, which is getting a lot of attention, it's been in the news, Nature Genetics says it's a major leap forward. It looks to me like it's about as good as the Framingham risk score. Okay? Another example. This is another one of these emails that I get, Cardiovascular Business. The headline said, novel artificial intelligence algorithm beats cardiologist models in predicting heart disease mortality. So one of the things I'm learning from this is that the headline often overpromises and underdelivers. And you know, we're going to have to all sort of recalibrate a little bit and try to figure out whether this new approach is actually an improvement or whether we want to kind of think about sticking with, you know, the stuff that we already are doing. So I looked up this paper. Again, the title of the paper, Machine Learning Models in Electronic Health Records Can Outperform Conventional Survival Models in Predicting Patient Mortality in Coronary Heart Disease. So this is just the abstract. It says here that the regression based on 586 unimputed variables with continuous values discretized achieved a C-index of 0.801, and that was compared to 0.793 for the traditional model. So if I were to show you the ROC curves for 0.801 and 0.793, you wouldn't be able to tell the difference. And from a clinical decision-making point of view, there is no difference. And yet, because of this tiny little difference, they trumpeted this in the headline and got this paper published. Oddly enough, when you read the full paper, this is from the discussion in the paper, so there's a disconnect between the title of the paper, the abstract of the paper, and the discussion of the paper. And Mike mentioned I'm an editor at JAMA. Sometimes this happens that, you know, the editors get very serious about the discussion and they don't want you exaggerating the importance of your work. So in the discussion, they say here, well, actually, we didn't find that discretization of continuous variables improved the model. That, oh, we thought we did, and we said that in the title and the abstract, but when we really thought about it, we really didn't. Okay. Here's another paper. This was published in JACC just a week or so ago. And in the conclusion, they said the genomic score developed and evaluated in this study strengthens the concept of using genomic information. So again, I looked at what the hazard ratio was here, and they said the top 20% had a hazard ratio of 4.17. They showed this curve here that the genetic risk score had this great improvement in the ROC curve, and it added to the conventional risk factors. So I plugged all of those numbers again into that paper that I mentioned from Archives of Internal Medicine, and you end up with this. Now let me compare that on this slide to what the same data looks like for coronary calcium. And I'm not trying to advocate coronary calcium, I'm just suggesting that we need to keep these kinds of things in perspective. If you look at the lowest 50% of the distribution in the MESA study compared to the top 11%, I showed you on that earlier slide that the hazard ratio was about 10. So when you plot that, you get a much greater separation than you do with the genetic risk score. So this is from the previous paper on the genetic risk score, and this is what it looks like with conventional risk factors in coronary calcium. So in a sense, where I am coming down right now is that we're a long way from where we need to be in terms of precision medicine. Because for precision medicine, just want to show you what it would look like and try to put a little reality on this. This is from that same paper in Archives of Internal Medicine. And what they point out is that if you're willing to set your threshold for positive test at a rate that gives you a 10% false positive rate, in order to detect 50% of the people who are true positives, you would need to have an odds ratio comparing the lowest 20 to the highest 20 of 40. 40. Thinking about where we are now, let's say with coronary calcium, we're about here, 8, 10, somewhere around in there. The genetic risk scores are actually not getting us higher than that. You saw the odds ratios for the genetic risk scores, 2.5 and so forth. So in order to really get this separation that is being talked about with precision medicine, we need odds ratios that we've never seen. And I think that, at least for now, we're pretty long way from being able to improve what we already have. And I think that's one of the messages. I'm going to skip this slide in terms of the time. I think in terms of what I wanted to leave you with, I think that it's fair to say that we've actually come a long way in terms of precision cardiovascular prevention. I think the evidence that I showed earlier in the talk that we're able to start separating people out into at least some basic categories. It's not perfect, but it's still, in my mind, we're not actually able to do much better even with the genetic risk scores. So I don't think we're at the point where one size fits all, and I think in cardiovascular medicine we need to be at least somewhat assertive about pointing out that we're not treating people as if one size fits all. And the last thing that I want to leave you with is there's a great quote, I think, from this guy named George Box. George Box was a British statistician who the Royal Statistical Society called him one of the greatest statistical minds of the 20th century. And in thinking about prediction models, one of the things that he said was, I'm going to take a little thought to think about what he meant. What he said is that all models are wrong, but some are useful. And the idea here is that the models are always wrong. They're always going to have this imprecision, and every model that I've looked at has this imprecision and this overlap and this inability to completely separate. But the utility of them is that it gets us from a guess to an educated guess. And I think that's really where we are with precision cardiovascular medicine, and possibly we're going to get further. But at least for now, I think we're doing a pretty darn good job. And we got some good tests to help us and some great doctors. And I hope that that's given you some perspective, at least, on both the past, the present, and the future.
Excellent. Thank you. That was fantastic. We have a few minutes for questions.
Thanks, Dr. Greenland. It's a good talk, always gets you kind of thinking. And one of the things that I've started to run into in my own clinic is that I have patients who are now showing up with a sheet of paper that says, Dr. Hurl, I had this analysis done that tells me which blood pressure medicine I should now be using and shy away from. And, my question is how much does it cost you to line somebody's pocket? Now let's start with the diuretic. Am I wrong?
So, based on what I understand, I think that we are kind of like what I was showing with those curves. We might be a little bit better with those genetic tests and being able to, somewhat specify. But I think what you're thinking is saying is, most people respond to the cheapest and easiest and most familiar. And most people are probably going to end up on more than one drug anyway, right? So you got to start somewhere, and I think that's not wrong. I guess you could argue that, well, if I have this information and my prior probability is a little bit higher to start with a different drug, maybe I would rethink that. But I don't think it's necessary that we completely change everything we do yet based on those kind of tests, yeah.
Yeah, outstanding talk and very thought-provoking. I really appreciate your candid insight about how imprecise we are in the precision world. I wanted to ask more of a rhetorical question. I'd love to hear your feedback. Until recently, for example, prostate cancer, that might not be a good analogy, but prostate cancer, we assume that we should be doing screening. A lot of these patients are going to die, not from prostate cancer, but with prostate cancer. But for coronary disease, we don't screen for it. Is there a time now that we should implement or we should consider screening for coronary artery disease? We have the best test that we can see the coronary process. And we're not relying on risk factors, which can be imprecise. What are your thoughts on that?
Yeah. Well, Mike and I have talked about this for a while, and many others have thought about that question too. It's not an easy answer, and I'm going to try to give a very short answer to it. I mean, it's like any other screening test. You have to consider both the positives and the negatives. One of the concerns that cropped up very, very quickly in my own thoughts about screening is that the guidelines came out a few years ago and sort of changed the landscape. So if we were trying to think about a screening population, which is the screening population now? Is it the group below 7.5%? Is it the group below 5%? What group are we even talking about? And do we believe enough in the accuracy of the first test, the pooled cohort equation, to be able to select out? And when you start trying to put all of this together and think about the cost effectiveness and so on and so forth, it does get complicated. My personal opinion, and I'm telling you a personal opinion here, my personal opinion is what we summarized in that JACC paper, where we said, I'll simplify this. If you're very high risk based on the pooled cohort equation, the evidence would suggest that a coronary calcium, even if it's 0, doesn't get you to low enough risk. So we don't think those people should be, quote unquote, screened. And people who are very low risk, we don't think that a coronary calcium score that's high will get you high enough. So we think there's a window in the middle. And then we can argue, I'm sure we could get different opinions in the room. What's that window? But I'm supportive of the idea that we should be testing in a window, and I wouldn't like to use the word screening because that makes certain people nervous.
Scott?
Thanks again, Bill. Wonderful talk. Do you have any thoughts on looking at populations that don't have coronary disease for learning about this process? For example, the study that was done in the South American Indians. What are your thoughts about that?
Yeah. So thanks, Scott, for that question. So a topic that I didn't talk about today is that our group has been very interested in trying to understand the low-risk people and trying to understand how we get more people to be low risk. So, for many, many years, we've been really focused on high-risk people, and that's kind of not inappropriate, right? The highest-risk people get the greatest benefit from the intervention. But the huge number of events occur in people who are moderate risk. And if we could get everybody to be very low risk, that would be a fantastic outcome. So, as you know, the American Heart Association now has this idea of Life Simple 7. And, trying to say, well, if your cholesterol is in the ideal range and your blood pressure ideal range and your blood sugar in the ideal range, body weight in the ideal range, non-smoking, et cetera, that you end up being really low risk. And we learned that from, even Western populations, that people who don't have the risk factors, and I could have shown you this slide, it's really amazing. People who have absolutely no risk factors, their lifetime probability of getting a coronary event is about 5%. People who have even one risk factor, their lifetime probability of getting a coronary event is about 40%. So from 0 to 1, you get this huge jump. And we've seen that in the Framingham study. We've seen it in some of the Chicago cohorts that we've looked at. So the challenge, and again, this is something that Mike and I were talking about, the challenge with coronary disease, I think, today is not understanding the risk factors. The challenge is getting people to do the right thing. And that's all of you.